Today we have Mercy Clinic neurologist Tariq Alam. He is a board certified neurologist and an electrodiagnostic medicine specialist. They give me lots of good words to work on here. He specializes in neurology, which is brain and spinal cord disease. Dr. Alam's education and training includes medical school at Dow Medical College in Karachi, Pakistan, and residency in neurology at St. Louis University. Additionally, his fellowship in clinical neurophysiology is from St. Louis University. Dr. Alam will tell you today that stroke is the #1 cause of preventable disability and the #4 cause of death in the United States. The good news is that he will also tell us that stroke is preventable, it is treatable, and is curable. Please welcome Dr. Tariq Alam.
Good afternoon, and thank you so much for inviting me to speak on stroke, something which is very close to my heart. And I also would like to thank all of you for your time to be here. I know it's a great weather outside. This is not one of the best times, to be inside a hall, but still, we'll try to make this a little bit enjoyable. I'll be talking about stroke. And stroke is something, which most people are aware of. Stroke is one of the leading causes of death in the United States. Unfortunately, it's a condition which makes people disabled, physically challenged, and that is where we really have to pay a lot of attention. We have to put in a humane touch to stroke and understanding stroke. It's a disease which is preventable, it's a disease which is curable, and I personally feel that as long as we can cure something, as long as we can treat something, we need to let the people know about it. Something, for which there's no cure, we obviously can't do anything about it. It will be good for academic purposes. But something, which is curable and which is treatable and which is preventable, we need to get the message across the community, to the people, to our folks over here, not just in Jefferson County, also in Missouri and all over. So, at the end of the discussion, we're all going to be stroke smart. We're going to learn how to reduce the risk of stroke, recognize some stroke symptoms, and how to respond. The reason why this is so important is because stroke comes under TCD. TCD means time critical diagnosis. Time critical diagnosis is something which has been enacted by the Missouri legislature because there are certain conditions whereby time is of the essence. Heart attack is one of them. Stroke is one of them because every second once someone has had a stroke, there are millions of brain cells that are dying. The thing is, in stroke, there are certain treatments that we can use, we can avail, but it can only be given within a certain time period. TPA is a clot-busting medication which can only be given within 3 hours. And every day I see this thing in my practice and at Mercy Hospital where I practice, patients are coming in after 5 hours, 6 hours, 12 hours, even after days, because they thought that maybe I slept on the wrong side. That's why, my one side was numb. Or maybe, headache, might have just been the flu or something. So time is of the essence in stroke. Let's talk a little bit about stroke facts. It's one of the leading causes of death in the United States. And close to 800,000 Americans suffer stroke each year. It's a huge number, 800,000 people. Close to 140,000 deaths each year just because of stroke. And from 1996 to 2006, the stroke death rate has actually fallen from 33.5% to almost 18.4%, which is almost 50%. And that's a very encouraging number, and we need to build on that number. Currently, there are over 6,400,000 stroke survivors in the United States. And I'm going to be talking about how this large number affects the healthcare system and the healthcare dollars. And there's a huge debate about healthcare and things like that. This number has a direct role to play in that. It's a leading cause of adult disability. The good news is that 80% of all strokes are preventable through just preventative measures. So prevention, being the best cure, cannot be better applied for stroke than stroke. And on an average, someone suffers a stroke every 40 seconds in the United States. So every 40 seconds, someone or the other will suffer a stroke. And there are many different types of stroke, and we'll talk about the types of strokes also. I thought that this is a very interesting slide, women and stroke, and I see a good number of women in the room. I don't want to scare all of you, but we just want to present the facts over here, okay? Stroke kills more than twice as many American women every year than breast cancer. We know so much about breast cancer, the pink ribbon, and breast cancer awareness lunches and walks and things like that. But actually, stroke kills more than twice the number of women than breast cancer alone. And that's a huge number. It's a huge public health issue right now. More women than men will die from stroke, and risk is higher for women due to higher life expectancy. Women will suffer greater disability after stroke than men. And women ages 45 to 54 are experiencing a stroke surge, mainly due to increased risk factors and lack of prevention knowledge. And we also know that as long as a woman is fertile and has enough estrogen and progesterone hormones, there is some protection against cardiac risk factors like heart attacks, stroke, which you can say is like a heart attack of the brain also. So once women will reach menopause, the risk of stroke and heart problems is actually going to increase because the protective effects of those hormones is no more. What is stroke? A stroke is when you have a sudden cessation or sudden stoppage in the blood flow to a part of the brain. The whole body is controlled by the brain. Whether we see, how we breathe, our heart rate, everything is controlled by the brain. The brain has got a programming button for every and any action that we possibly can even think of. So if any one part of the brain gets affected because of a stroke, there's blockage of blood flow because of a clot or whatever, that particular area of the brain that provides that function will get affected. So if that area supplies sensation, or sensation will get affected. If that particular area supplies strength, weakness will come into play. If that particular area, helps us in speech and language, then speech and language will get affected. So you see, the symptoms of stroke are all over the place. And that is one of the biggest questions which patients ask me. How am I supposed to look out for what symptoms and what signs? And this is something, which you'll be also talking about. So lack of blood flow to the brain caused by a clot or rupture of a blood vessel. 87% of all strokes are ischemic stroke, or there's a blood clot which actually prevents blood flow to that particular part of the brain. And the remaining 13% to 15% of stroke are actually, hemorrhagic stroke or bleeding stroke. So this is a nice cartoon over here. This is a blood vessel. You can see a blood vessel. Blood flows through this. And this is how a plaque develops. So you see, as a plaque develops, this area, this lumen over here, is becoming very, very narrowed. And although there's a large lumen over here, once blood goes over here, there's a very small area through which the blood has to go. It doesn't take too much for this small area to get blocked also. So once this area totally gets blocked, or there's less oxygen going than what is required by that particular part of the brain, what happens? Because of less oxygen, the brain cells are going to go into irreversible death. And that's when stroke will happen. A hemorrhagic stroke or a bleeding stroke is something which is entirely different. That is when the blood vessel just ruptures. So a blood vessel will just rupture and blood will just leak out, and that can affect the area of the brain which will control that particular action. There could be an aneurysm. An aneurysm can rupture. If someone has got high blood pressure, because of high blood pressure, the blood vessel can burst open. So there are different mechanisms how one can develop a bleeding stroke. But broadly speaking, stroke is defined or put under two different categories: ischemic stroke or hemorrhagic stroke. Now, this is the blood vessels that run on either side of our neck. The heart is over here, the brain is over there. So obviously you need blood, to flow from the heart all the way up to the brain. There are two large blood vessels on either side known as the carotid arteries. One of the biggest causes of stroke is when this carotid artery gets blocked, because all the other blood vessels that supply different areas of the brain are actually branches of that carotid artery. So you can see over here that this is the common carotid artery, which actually divides into the external and the internal branch. The internal branch goes all the way up to the brain and then supplies different areas of the brain. It's very common for the internal carotid artery to get blocked because of plaques. It could be because of smoking, it could be because of high cholesterol, it could be because of diabetes, it could be because of a number of risk factors, which we're going to talk about. But this is by far the most common cause or the most common blood vessel that gets blocked before people will suffer a stroke. We'll talk a little bit about stroke symptoms because that is very, very important. You can see over here that sudden and severe headache could be a stroke. Trouble seeing from one or both eyes could be a sign of a stroke. Sudden dizziness or trouble walking could be a sign of a stroke. Sudden confusion or trouble speaking could be a sign of a stroke. Sudden numbness or weakness of the face, arm, or leg, those could also be sign of the stroke. So you see, it's a whole gamut. There's not just one symptom. Someone who's suffering from multiple sclerosis, which is also a neurological disease, might have these symptoms. Someone who's got diabetes and has developed nerve damage, neuropathy because of diabetes, will also have numbness and weakness and things like that. So how do you differentiate, you see, if this is actually a stroke happening or is it just a flare-up of your diabetes or any other condition? And why are we interested in knowing that? Because stroke is a medical emergency. The key word over here is sudden. Sudden, 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 and sudden. Something that has been going on over a certain period of time is unlikely to be a stroke. Anything that happens suddenly, I was fine. I was having lunch and I was fine, and the next moment I realized that I'm totally numb on one side. That's sudden. Then that is a red flag. But if you've got numbness and tingling, which has been going on, it came in gradually and then, went up, that's probably not stroke. So the key word is actually sudden. And that is what I tell patients, that is what I tell, folks whenever I give presentations, that you really need to be careful about the word sudden. Sudden, anything neurological needs to be evaluated, and a stroke has to be ruled out until proven otherwise. This is what the American Heart Association and the American Stroke Association would like to let everyone know about it. The FAST fact. Stroke strikes fast. And we need to know what FAST stands for. People in the community, obviously are not going to be doing a neurological examination on someone that they're suspecting has a stroke. But we do ask our folks to remember these 4 simple things. Anytime you suspect someone is not acting right, first look at their face and ask them to smile. If there is an asymmetry, that is concerning, because there should be no asymmetry when you smile or when you blow out your cheeks. It should be equal on both sides. Secondly, arm. You ask the person to raise one or both arms. They should not be able to raise one arm. Speech, you ask the person to speak a simple sentence, any simple sentence. If there's anything which is not right, like say if they mispronounce words or if they get the sequence wrong, if they're not able to follow commands, if the naming is affected, if their repetition is affected, then those are concerning factors. And if we think that someone is suffering from any of these 3 symptoms, we should call 911 as soon as possible because time is of the essence. Every minute matters. So these are by far the most common symptoms that people will ever have if they suffer from a stroke. In the previous slide, we talked about having numbness and things like that. Those are less common, but anytime anyone has any of these, the facial asymmetry, weakness in your arms or your legs, or speech problems, that is definitely a red flag. Let's talk a little bit about mini stroke. This is something which we hear a lot, mini strokes. I had a mini stroke. What is a mini stroke? A mini stroke is also known as a TIA. A TIA is a transient ischemic attack, so it's just transient. It is a warning sign of a future stroke. That is why we give so much importance to a TIA. And 40% of patients who've ever had a TIA will actually have a future stroke. So it's very important to know if someone has had TIA and what the signs and symptoms are of TIA. Symptoms of TIA are the same as stroke. So what's the difference? The difference is that TIA symptoms can resolve within minutes or hours, and there will be no permanent damage to the brain. So if someone has any symptoms, neurological symptoms, or the symptoms like we've discussed, if you come to the ER or if you talk to your physician, and if they do, say, a CAT scan or an MRI of your brain and everything's fine, there's no sign of a stroke, then that's probably a TIA. I've seen this thing many times. Patients will come in and they will say, I woke up this morning and I had numbness and tingling on my one side. And I came into the ER did a CAT scan, the CAT scan was normal. I was told, well, you're fine, go home. Well, a CAT scan is going to be normal when it comes to a TIA. We just talked about that. There will be no permanent damage. That does not mean that you've got a clean sheet of bill as far as your health is concerned. That means you really need to see a neurologist. You need to get your risk factors sorted out. You need to have further imaging, because 40% of the time that person will go on to develop a full stroke. 5% of those patients who are at risk of developing a future stroke with TIA will actually have a stroke within 1 month. 12% will have within 1 year. 20% will have within 2 years. And 25% will have within 3 years. So there is a 1:4 chance that you're going to have a stroke within 3 years after suffering a mini stroke. And that's a big number, 1 out of 4 people. There are certain perceptions about stroke which people do not know in the community. And because I see a lot of patients, I see a lot of folks out there, I thought it's a good idea to talk about some myths and some realities. The myth is that stroke is not preventable. And I told you that up to 80% stroke are actually preventable. The myth is that stroke cannot be treated. Stroke does require emergent treatment, and we do have emergent treatment available. The myth is that stroke only strikes the elderly. But the reality is that anyone can have a stroke. Pediatric stroke is a huge risk factor now. There's a whole pediatric stroke registry. People have been suffering stroke even when they're in the womb. Stroke happens in the heart, but it's actually a brain attack. Stroke recovery ends after 6 months. If I did not get better after 6 months, then probably I'm not going to get any better. The reality is that recovery process is a lifetime process. Patients do get better. Yes?
One question. Are all hospitals now equipped with this treatment, or do you have to go to a specific?
That's a very good question. As I said, that the Missouri legislature has enacted this TCD law, which is the time-critical diagnosis. Stroke is one of them. So most hospitals have to be either a level 2 or a level 3. Okay. Level 3 has got 2 categories. You can go to the hospital, they can give you the clot-busting medication, but if they do not have the capabilities, they will ship you to a larger facility. Most university hospitals where they have a lot of imaging techniques and a lot of specialists available, they will come under level 1. According to this TCD law, the EMS is bound to take you to a level 2 hospital. Yeah, so that's good. So we know now, because a lot of folks were going into these small community hospitals, and then there was no neurologist over there, and they were waiting in the ER for like 3-4 hours, 5 hours, and then someone would come in and they'd say, oh, the patient has a stroke, and then ship them to St. Louis University or Barnes Hospital. By the time you come there, you've had permanent brain damage. So that's why the legislatures have recognized this, and they have come up with this law, the TCD, the time critical diagnosis. EMS is supposed to take you to a level 2 hospital. This is a slide which is very interesting, and I'm very passionate about this. Unless we do not have a clear understanding of what a particular disease process entails or what is the cost of it, we are never really appreciative of it. The estimated direct and indirect cost of stroke in the United States just in 2010 was $73.7 billion. That's a huge amount of money. just for one particular disease. But be careful, we're talking about both the direct as well as the indirect cost. As I said, the reason why stroke is so important is because once you've had a stroke, you've been through rehabilitation, you've had your hospital stay, you've had your imaging and everything, your physical therapy, people become physically challenged. They end up in nursing homes. They end up in skilled nursing facilities for consequences of this stroke. So it's all about missed work. If someone is a productive member of society, that person is now on disability. Imagine who's paying the cost for nursing homes, for extra physical therapy, and that person, might live for another 20, 30 years. We are having strokes in young patients now. If someone develops a stroke at the age of 30 years of age, and if they have their life expectancy, say, 80 years, for 50 years, they will be dependent on the state for their care. So the direct and the indirect cost of stroke is $73.7 billion, and this number I'm pretty sure has just gone up in 2014. The mean lifetime cost of ischemic stroke is about $150,000 in America. Only when I look at these numbers, that's when I get passionate, and I really, really want folks to know about the preventative aspects of stroke, because this is something that we can prevent. We can get these numbers down. So how do we prevent a stroke? The National Stroke Association recommends that you follow these guidelines to help people reduce the risk of stroke. These are some of the risk factors that are important in stroke: hypertension, cardiac disease, atrial fibrillation. This is an abnormal heart rhythm when your heart does not beat in a synchronous fashion. And because of that abnormal heart rhythm, what happens is that blood backs up in the heart. Anytime blood backs up anywhere, it develops into a clot. The next time the heart will start beating normal, those clots will get showered up from the heart, and they can go and block different blood vessels in the brain. So that's atrial fibrillation. Hyperlipidemia, or high cholesterol levels, diabetes, carotid stenosis, which is blockage of the blood vessel in the brain, and studies have shown that smoking is directly related to the blockage of blood vessel in these arteries. If you have had prior TIAs or stroke, elevated homocysteine and sleep apnea. I'm going to talk a little bit about elevated homocysteine. Homocysteine is basically a vitamin that is extremely essential for proper functioning of red blood cells. And we know that red blood cells carry oxygen to any and every part of the brain. This homocysteine needs vitamin B12. So vitamin B12 is absolutely important to keep the homocysteine in check, which will prevent against stroke. And I have seen this thing in the 2 years that I've been here in Jefferson County, that folks over here are really, really low in B12. B12 is basically found in red meat. I know people eat a lot of red meat. Okay. People who are vegetarians, they are the ones who basically have a deficiency of B12. But I've still seen a lot of people who've had low vitamin B12s, and because of that, high homocysteine levels, because their GI system is not able to absorb the B12 from the red meat that they consume. It's very important when you talk to your primary care physicians, who does annual blood work, will check your cholesterol levels, your CBC, and your other electrolytes, that they add vitamin B12 annually to your labs. If it has not been done, you can do it now. And sleep apnea. Sleep apnea has been known to be one of the most important factors for stroke. It's something which is new. We were not aware of it, Sleep apnea is running in endemic proportions in this country, just because of the obesity that we are faced with, obesity as a whole. What happens in sleep apnea is that when we sleep at night, the weight of the neck will actually fall on our windpipe. When the weight of the neck, the extra fat, the extra muscles over here will fall on our windpipe, it's actually going to suppress the amount of oxygen that will be circulated in the lungs to get enough oxygen. And then when we sleep at night, we know that whenever humans sleep, the respiratory rate goes down. That's a normal reaction. So your respiratory rate is going down when you sleep. The weight of the neck is actually suppressing or pushing down on your windpipe. Less oxygen is going to your brain, and over time, those patients will have sudden cardiac deaths, or they will just wake up with a stroke. Yes?
Now, is that what causes people to snore?
Yes. So sleep apnea, how do you recognize sleep apnea? Or what are the signs and symptoms of sleep apnea? If you snore at night continuously, if you stop breathing at night, people will stop breathing. And if you do a sleep study, in the sleep study, they actually monitor your sleeping patterns and everything. And you will be surprised because I've seen those reports. Patients have actually quit breathing for up to 20 seconds. Imagine just holding your breath for 20 seconds. We'll all be gasping for air. It's very common in patients who've got sleep apnea, but they will never recognize that. They will wake up in the morning and they will have a headache and they'll be tired and they'll be fatigued. And they will say, I never had a restful sleep. Yes.
In regards to B12.
What's that?
In regards to B12 vitamin, we just had our blood tested at our primary care physician. And it came back on a sheet that we always ask for, and it said the reading should be between like 200 and 900 of something. Mine was 1,600, hers was 1,100. Is there such a thing as too much B12?
No, that's fine. That's
okay.
fine. Because the thing is, if you get a B12 injection or if you take B12 tablets, your numbers are just going to go up. That's okay. Yeah. The normal numbers are 200 and above, but 30 to 40% patients can even have symptoms with numbers of 400 or less. So anytime the B12 number is going to be less than 400, I tell my patients, get on supplements. Yes.
Well, I did a sleep study and was diagnosed with sleep apnea, and then I lost weight. And I lost enough weight so that I no longer need the CPAP.
Okay.
But I still braid down when I go into my REM sleep, so I'm on oxygen for that. But there seems to be nothing I can do except continue to be on oxygen because I'm taking all my pills and stuff. But that I still go too deep into sleep when I.
And you stop breathing?
Yeah.
Okay.
And when I did the sleep apnea the first time, I was snoring and but I stopped breathing 77 times an hour, and that's more than once a minute I stopped breathing.
Yeah.
And I was like, I stopped breathing 77 times.
Yeah.
It was the medical assistant who explained the results to me, not the doctor.
Yeah. So this is a challenge. There are a lot of people like you, who are suffering from this problem because you use the CPAP machine, but you're still not getting any better. Now, there are a lot of different treatment options for sleep apnea. CPAP is one of them by far, but we also know that it's a nuisance, if I can use that word, because it's not easy to have a mask on your face and sleep the whole night. We have dental devices now available. We also have sleep apnea surgery available. There are centers at St. Louis University Hospital. They will do sleep apnea surgery. So what they will do is, if you've got a lot of fatty tissue around, they will just go and clean it out, and patients have done very well.
Awesome.
Yeah. So these are some of the risk factors for stroke. How many people in this room are suffering from at least one risk factors? At least one risk factors. So we have almost 50% of the population just in this room.
She has a question.
Yes.
I've been getting headaches lately,
You've been eating what?
headaches lately. But every time I get one, I get a sharp pain right here. And when that pain goes away, the corner of this eye is all bloodshot red.
Okay. This has been going on since how long?
A little over a week.
There are many different types of headache syndromes also, okay? Many different types of headache syndromes will basically cause redness or tearing in the eyes. It will be just focal to one areas. These conditions can also be known as cluster headaches. They can also be known as trigeminal, cephalgias, things like that. So you'll probably need to have an evaluation as to what type of that is. But the headache in stroke is pretty much global. It's all over. Some of the behavioral risk factors, those were medical conditions. But a lot of these risk factors for stroke is something, that we have just put on ourselves. Cigarette smoking, alcohol abuse, physical inactivity, recreational drugs, especially meths and cocaine, very, very important for stroke. And some antipsychotics, especially the older generation antipsychotics, have been implicated as cause of strokes. And this is very, very important because the elderly population is, as it is, more prone to develop stroke because of multiple other risk factors. And then The old generation of psychiatrists, this is all they've studied, old generation medications, and they'll put patients on these medications because of dementia or because of hallucinations or confusion, things like that. Those medications can cause strokes also. We've got a lot of new generation antipsychotics available, and I still see patients in Jefferson County who are on these old generation antipsychotics, and I always tell them that you and your psychiatrist and I, we need to work together, and we've changed a lot of medications.
Can you give an example of the old generation?
Haldol, risperidone, these medications especially. So, some of the guidelines which the American Stroke Association and the American Heart Association will recommend is that you need to know your blood pressure. You need to have your blood pressure down. You need to check it at every doctor's visit. This is something which is treatable. We've got over 50 medications to treat blood pressure now. You have to find your medication. When you have 50 different types of blood pressure medications available, there is really no excuse to say that my blood pressure is not in control. You need to be proactive with your primary care physician in trying to find out.
Then why does some doctors put you on so many different kinds of blood pressure medicine?
The reason is because some studies have also shown that augmentation therapy is actually better than just monotherapy. There's a synergistic effect which many medications have. We see that in many other medical conditions, even in conditions like dementia, like for Alzheimer's, we have some treatment medications for Alzheimer's. Rather than just one medication, we say combination treatment is actually more beneficial. So that's okay. Yeah.
So is there something that you can give for people with dementia or Alzheimer's to help them?
Yeah, we do have medications. If your memory has been, if you're in the early stages of memory loss. We call that condition as mild cognitive impairment.
Well, I got a sister-in-law, she's just went off the deep end.
Yeah. A lot of folks don't know. Maybe, we can do a session on dementia syndromes, because I know that it's a big public health issue also. Yeah. Yeah.
As far as blood pressure is concerned, is lower more hazardous, or mine runs 105 to say 50? And is that indicative of what?
You're talking about the number, the blood pressure number? The ideal number is it should be less than 140 by 90. 140 should be your top number, and 90 is your bottom number. Your blood pressure needs to be less than that. Anytime the number is 140 by 90 or above, you've got hypertension. And that's directly related to stroke risk.
Is low pressure dangerous?
Low pressure is also dangerous. The reason why low pressure is also dangerous, and I've seen patients who've had such low pressure that they've actually stroked out, is because if you've got low pressure, you see the heart is here, the brain is there. So the heart has to pump blood against gravity to go up to the brain. It needs a lot of energy. It needs to have a certain pressure. If your pressures are low, how do you expect the pump to pump adequately that the blood is going to flow against gravity up to the brain? Yeah.
Generally is running around 50. Should I talk to my cardiologist?
I'm sorry, I didn't get.
His bottom number
My low
is
is
50.
generally around 50.
Should he talk to his cardiologist about?
You need to, yeah. And there are medications. People who run their blood pressure chronically on the lower side, there are actually medications to help that condition also. Yeah, there are
What is the
medications.
low? Are you considering?
It should not be less than 90, the top number. The top number should not be less than 90. Yeah. I'm not saying that anyone who's got less than 90, will develop a stroke. I'm not saying that. But you're increasing your risk because obviously the brain is here, the heart is here, you see. So the physics is involved. It's going up against gravity. So you need to maintain a certain pressure.
So what's the bottom number should be then?
The bottom number is not really that important when it comes to low pressure, but definitely if it's 40 or low, then I'm going to tell my patients, you start drinking lots of fluids, make sure cut down on your blood pressure medication, get that number up a little bit. Yeah. Secondly, you need to find out if you've got atrial fibrillation, because this is an irregular heartbeat. It's very important because if you've got atrial fibrillation, there's a different treatment for this condition. Usually, for stroke, we give Plavix or aspirin and things like that. If someone has got atrial fibrillation, we will put you on blood thinners so that the blood clot in the heart can actually be dissolved. So the treatment is different. So that's why it's very important that you know if you have atrial fibrillation or not. And if you smoke, you need to stop that. If you drink alcohol, you need to do so in moderation. Okay? The American Heart Association says that small amount of alcohol might also be good actually. Okay? What's the exact rationale behind that? That's something, which is still, a field, which is developing. But we don't say that just don't completely stop alcohol, but do so in moderation. You should know your cholesterol numbers, and if you're diabetic, you need to work with your doctor to control your diabetes. We need to include exercise in our daily routine. And we need to have a low sodium diet and low fat diet. If we have circulation problems, that needs to be addressed. This is very important because not exercising is a big public health issue now, and that is also directly related to the obesity problem that we face, not just in the United States, but all over the world. We have seen that just 20 minutes of brisk walk a day, 20 minutes of brisk walking 3 times a week, just 3 days out of 7 days, 20 minutes is actually very, very beneficial for your heart and your brain. Just 20 minutes. We're not saying you need to exercise daily or you need to walk daily for maybe 1 hour or 2 hours. No, 20 minutes, 3 times a week.
So if you do it in the pool, does that count?
Anything to stimulate the blood flow. What happens during exercise? During exercise, the very tiny blood vessels that are really deep down in our muscles, in our brain cells, in our heart, they get opened. That is the concept behind exercise.
Well, the reason I asked, my doctor told me I got bad arthritis in my legs, and he told me to walk at least 3 times a week for 20 minutes in the pool.
Yeah, that's fine.
So that would work.
That's fine. Aquatherapy is actually very helpful in patients who've got diabetes also. Yes. Oh, sorry, arthritis. Yeah.
I wanted to ask about sodium because I'd always heard to lower your sodium. But recently I've had a friend sodium in the brain.
Low sodium? It's probably not low sodium, which in itself has caused dementia. But if someone is suffering from low sodium, and if you rapidly correct that low sodium, that is something which can cause brain damage. That's a whole condition. It's known as CPM, central pontine myelonitis. So patients will come in, the sodium level is very low. They'll be put on fluid restrictions, things like that. And, most doctors will say, okay, we need to, bump up the sodium level. But you need to do it only at a certain level. If you do it too rapidly, it could result in irreversible brain damage. Yeah. So these are lifestyle changes. We've talked about this. This is a very important slide, and I, again, like to discuss this thing with all people that I talk about stroke. If you walk 10,000 steps a day, you will just lose 1 pound per week. So you see, that's not very encouraging. But we can still do it. So 10,000 steps a day to lose 1 pound a week. That is what studies have shown. You will lose 1 pound only if you walk 10,000 steps. But don't fret, because most of us walk many thousands of steps a day. Okay, we don't know, but we usually walk. On an average, I think, a person would do maybe 7,000 to 8,000. That's why we need to fill the gap with exercise. So why people don't recognize and respond to symptoms? A, people don't know about the symptoms of stroke. They are in denial. They think that nothing can be done. They worry about the cost. They think that symptoms will go away. And there's a fear of hospitals, or they don't trust hospitals. Okay? I have mentioned about this clot-busting medication for ischemic stroke. This clot-busting medication can be given only within 3 hours of stroke onset. So that is why time is of the essence. If you have a stroke, you really need to get to the ER, and you need to be evaluated if this medication, TPA, which is a clot-busting medication, can be given. If you've got a hemorrhagic stroke, there are certain neurosurgical procedures that can be done to prevent that from happening. There are certain contraindications to TPA. Obviously, if you've had surgery within the last 3 months, or there's a history of bleeding disorder, then they're not going to give you the clot-busting medication. I'm not going to go into the details of this. New studies have shown that TPA, which is a clot-busting medication, can be given up to 4.5 hours in selected patients. The window was only 3 hours, but now it's 4.5 hours in selected patients. You need to be less than 80 Absence of diabetes, absence of prior use of blood thinners, and less than 1/3 of the brain has to be involved in strokes. If you have any of these 4 features, you are not eligible for 4.5-hour window period.
I had a stroke about 5-6 weeks ago. In
Okay.
the middle of the night, I woke up and of course my leg was paralyzed, and I thought, well, maybe it's asleep, and you know, so I didn't go to the hospital till the next morning. And I asked them then if it would have been better if I had come, and they said, I'm 86 years old, that they couldn't give me that.
The medication?
Right.
Well, I don't know your medical history in detail, okay?
This is the second one I've had.
The second
other
one.
was, I woke up and my arm was paralyzed. Now, it stayed paralyzed for several days. The leg went away.
I see.
I walked and walked and walked.
This is always a challenge because when people wake up from the sleep with symptoms, then we don't know when they were normal last. Even if you woke up, say, 2 hours ago, we're not going to go by those 2 hours. We're actually going to go by when were you last seen normal. And that could be at 7 p.m. last night, that could be at 6 p.m., that could be at 5 p.m.
I always have these, it's always, say, 2:30, 3 o'clock in the mornings when I wake up. And always, I
Totally.
just had
Yeah,
two,
yeah,
but.
yeah. There are, as I said, certain contraindications for this medication. I don't know what your medical history is. There might have been some contradictory factor issues. That's why maybe the physician might have told you that you're not eligible for the clot. You were not eligible for the clot-busting medication.
I don't know.
Yeah.
I went to here. I'm originally from Illinois, so I'm with different doctors now that I'm here with
I
my
see.
daughter. And I don't have high blood pressure, and I have low cholesterol count, but I have high triglyceride.
That's also a very important
Is
factor,
that,
yes.
my-
It's within the same category of high cholesterol.
And sleep apnea. Is there something for that other than all this mask?
Yeah, as I said, that there's a dental device which is available now, okay, a dental device, and we also have sleep apnea surgery. Large university hospitals like SLU or WashU, they offer that.
I'm too old for the
Yeah.
surgery.
So dental device is something, which could be very good. Dental device. What they do is, it's a dental device which you will put, it's just like, having artificial teeth, but, it will just open your windpipe in such a position that enough air flows in and it does not compress on your windpipe, the weight of the neck.
That sounds like it would be a good thing for me,
Yeah,
doesn't it?
yeah. Talk to your doctor about that, yes.
If heretofore, before coming here today, I've always thought to myself that if I would get, say, a global headache or one of those stroke signs, or a loved one did, I would, or have them quickly chew an aspirin until other help. Seeing that slide, wouldn't be eligible for the clot-busting medicine.
You can get aspirin. You see, this is always a tricky question. And someone, if they have a heart attack, we always say, you're having chest pain, you're considering someone has a heart attack, take aspirin. The problem with stroke is, unless you've not had a CT of your brain, we don't know if you've had a bleeding stroke or if you've had a ischemic stroke. If you developed a bleeding stroke and then you're taking aspirin, you're just making the bleeding worse.
Right.
You see? So that's a very critical situation. That's why the brain is so different than the heart. You see? So that's why we say that anytime you suspect that you've had a stroke, you just come to the ER, get a CAT scan done, get a neurological examination. Because if you've had a bleeding stroke, you don't want to be an aspirin. That's just going to make things worse. Yeah. Are we short on time? Okay, we'll just wrap up. Let's see. Other preventative medications, so apart from aspirin, Plavix, we have some new medications also, Egrinox. Ticlopidine is not really used because of side effects. We have blood thinners available, Coumadin. New blood thinners have come in the market, Xarelto and Apixaban. Coumadin is something, how many of you own Coumadin over here? Blood thinners. Okay. So you need blood tests, right, every so often to see if your INR is within the normal range. The good thing about these other medications is you don't need your blood levels to be checked. Okay. So that's a good thing. 10% of stroke survivors will recover almost completely. 25% will recover with minor impairments. 40% will experience moderate to severe impairments requiring special care. 10% will require care within a skilled care or other long-term facility, and 15% patients will die shortly after a stroke. These numbers, although they look daunting, they're still very encouraging numbers from what we had, say, 10 years ago. Stroke rehabilitation, physical therapy, occupational therapy, speech therapy, recreational therapy. So medications and therapy will have to go hand in hand. There are some long-term complications of stroke like spasticity, stiffness in your muscles, depression, anxiety, memory issues, urinary incontinence, developing blood clots because you're paralyzed on one side, you're not moving your legs, pneumonia. These are some of the common complications that we see. This is an example of a patient with spasticity. They're very, very stiff. We can treat these spasticity with Botox injections. Patients are able to move that limb again. And then lifestyle changes for survivors and caregivers. These are pretty much the issues that we've all obviously talked about. So the last slide, I think this is the key over here. Stroke is preventable, stroke is treatable, and stroke is curable. It's just that our folks need to know about the symptoms and they need to know when to seek medical attention. And the sooner it is done, the better it is. I'll be happy to take any questions if you have. Yes?
My husband has AFib and he is on the Xarelto, but lately I've been noticing on TV commercials it's saying Xarelto is not so good for you, that there is complications.
Very few complications. It can cause some GI side effects, but the complication that Coumadin has, which is bleed in the brain, is significantly lower than Xarelto. I don't know which TV commercial was that. You see, there's a lot of rival pharmaceutical companies also, so I don't know who made that TV commercial, but it's definitely a medication that has been approved by the FDA. It's there. You know, we have used it. We've had good results. It saves healthcare cost because obviously, you know, you don't need to get your blood checked, you know, every week or every 4 weeks, things like that. It prevents unnecessary or too many doctor office visits also. So these medications are good. You know, I don't think so there are any long-term complications. Otherwise, it would be out of the market.
Yeah, but those other medicines, don't they have other bad effects that could affect?
Very minimal. They can maybe cause some GI bleeding, but with regular monitoring, you know, patients are fine.
Oh, okay.
Yeah, most medications are very well tolerated.
Okay.
Yeah.
So how can they get on TV and scare you to death of taking any medicine?
I think that's going to be a talk about another day. Thank you so much. Thank you.